So, ischemic heart disease, by the way, this table is from Master of the Board Step 2, right? Ischemic heart disease and generally speaking, coronary artery disease, you might have chronic stable angina, which is your office patient, or you might have acute coronary syndrome patients. What is the difference? This is my emergency department patients. What is this one? This is atherosclerotic plaque. What is this? There is a clot happening here. Is it acute coronary syndrome? No, this is office patients. These guys are acute coronary syndrome, STEMI and non-STEMI, MI and unstable angina, transmural infarction or transmural infarction or subendocardial infarction, old terminology. But the most accurate definition is based on the ST segment. Is it elevated or it's not elevated? Okay, so ladies and gentlemen, how to treat these patients? This is demand and supply problem. Are you in pain right now? No, but I will give you aspirin. Oops. I will give you aspirin to live longer. Beta blocker and nitrates. What does beta blocker and nitrate do? Beta blocker tells you to go slower and live longer. If you have problem with heart rate of 80, you should be fine with a heart rate of 60. Sure. Nitrates, I will dilate your vessels, including your coronary artery. So you feel a bit less pain. What about heparin? No, there is no clots. What about GP3B2A? Oh my God, which medications? 2B3A inhibitors? Epciximab and tirofibans and Febans and epciximab and no. Why? Enough. Aspirin should be enough. Thrombolytic is TPA. No. There is no thrombus. Calcium channel blocker. No. Ladies and gentlemen, we don't give calcium channel blockers to patients with ischemic heart disease, coronary artery disease, because they didn't show mortality benefits. Do we ever use them? Sure. Always and always and always as an alternative to beta blockers. If I cannot use beta blockers, I can use them. But if I can use a beta blocker, no. Warfarin, no, there is no clots. Antiplatelet, second, you mean Plavix clopidogrel? No, it seems that that one is enough. Check my statin, 95%. My LDL cholesterol is high. So you will need to give me a statin. Which medications in these patients showed mortality benefits? Aspirin and a statin. And beta blockers, maybe. What about nitrates? It's just pain relief. Do you do emergency coronary intervention for me right now? No. Do you want to check me? Sure. How do you want to check me? You will put me on treadmill? Elective? Not right now. Right now you're not in pain, but I will set an appointment. I will refer you to a cardiologist. They will do exercise tests for you, exercise tolerance tests for you. And they figured out that you have problem with coronary perfusion or not. And if yes, next step is angiography. Why? Because it will give me how to manage you. Are you a cabbage patient? coronary artery bypass graft, or you are stentable, I can put a stent in your clogged, blocked arteries and check on you medically. That's the plan for stable angina. Ladies and gentlemen, cardiology is very similar to OB gynecology. The same way that in OB gynecology, we do pap smear, colposcopy biopsy, and endocervical curettage, and then conization and LEEP. Exactly the same thing here. We start with EKG, we go a little bit further with exercise tolerance tests, treadmill, and next step will be angiography. That's the whole thing about chronic stable angina. Are we fine? Aspirin is an antiplatelet. I was talking about the second antiplatelet. Dr. Johnny, non-STEMI, unstable are two different names for the same thing. They come with acute chest pain. Acute chest pain. I'm talking about chronic stable angina right now. I was talking about chronic stable angina. Are we all fine and good and okay? Because if you're good, we can go at Dr. Tarambir. Antiplatelet means second antiplatelet. Now you're dealing with a patient with acute chest pain in your emergency department that might have happened while he or she is repeat what chronic stable angina? What to repeat about chronic stable angina? What to repeat about it? I have a patient that whenever they exert, they do exercise, they do some activity, right? They get chest pain. It's always the same amount of pain, the same quality of pain, the same duration, the same amount of rest that make them feel better. It never happens to them at rest because resting angina will make me unstable, not stable. Resting angina will make me unstable, not stable. What to do for these patients? Medical therapy, aspirin, probably statin because their LDL is probably high. Beta blocker, go slower and live longer. With a heart rate of 80, you get chest pain. What about 60? No, I'm fine with 60. Okay, beta blocker. Nitrate, a vasodilator that dilates their coronary vessels as well to increase the supply. They have a demand and supply problem. How to go further? Elective treadmill test, exercise tolerance test. And when I have a positive exercise test, means I have coronary artery disease. Next step, angiography. Not urgent, not emergent, elective basis. Why? Because you want to check whether I am, for example, free vessel disease, that you need to do CABG for me, coronary artery bypass graft, CABG or CABG, chronic artery bypass graft, or you can stent me. That's chronic stable angina. Let's come to unstable angina or STEMI and non-STEMI. What is the difference? ST segment. What is the presentation? At the same acute chest pain that might have happened even at rest, or while I was shoveling snow, or while I was running, or I was playing tennis, or I was playing squash. How do you check me? EKG and enzyme? EKG and enzyme? How to differentiate them from each other? The name is clear. ESTEMI, ST elevated MI, or non-ST elevated MI. My ST segment is elevated or not elevated. That is the difference. Elevation or not elevation. That's the problem. Okay then. So, oopsie. What is the recipe for the treatment of acute coronary syndrome? What is the recipe for acute coronary syndrome? This is the recipe for acute coronary syndrome. This is the recipe, the treatment, the treatment for acute coronary syndrome. It's the same Mona bash Mona. I don't know what do you want to do with Mona, but Mona bash, Mona C bash, Mona me, right? Or something more Urdu, Hindi, Farsi. Oh, man, tabah. O is O, oxygen. Man is me. Tabah, dying. The same as Mona Bash or Bash Mona or Bash C Mona, whatever. It's the same thing. It's the same thing that you remember from the past. O, oxygen. What does it do? Does it change my mortality? No, it just makes me feel better. Adult, you want to remember one number for O2 saturation, remember 90. You want to remember one number for kids, 95. Although pediatricians might say 93, but we don't kill each other over 2%. They gave me 2% discount, but O2 saturation in adults around 90, in kids around 95. Man, me, morphine and nitrates. These are pain medications. These are pain medications. Do they change my mortality? No. Nitrates, sure. My time, it was nitrate infusion. Now we have a spray, we have patch, we have a lot of things. The major thing about nitrates, the patient might get a little bit headache and hypotension because it's vasodilator, sometimes nausea, vomiting. But contraindication to nitrate that we cannot afford to forget is taking boner pills, erectile dysfunction pills. You can see my screen, right, guys? You can see my screen, right? Good. So nitrates, but the major thing that we cannot afford to forget, guys, these patients are usually old patients, so they might take boner pills, erectile dysfunction pills, and now they are in your emergency department. The question that I will ask from my patient is, are you taking any erectile dysfunction pills? Do you take any boner pills? Right? There should be 24, 48 hours time difference between the last time that they took Viagra or Cialis for the erection. Why? Because nitrate and these guys is a no-no. Too much vasodilation, which is not good even for my heart. It can kill me. M, morphine, the best painkiller on the planet. 2 milligram morphine sulfate, slow infusion, IV, even IM. It makes them a little bit sedated. It makes them a little bit feeling less pain because they are agitated as well. Does it change mortality? No, these are pain medications. But these medications are mortality medications. These medications that are coming now are mortality medications. I put a star here on the T because I want to talk about the T a little bit later. I put a star here on the T because I want to talk about the T a little bit later. T, I put a star because I wanted to tell you that's STEMI receives it. STMI will receive thrombolytic. T for TPA, thrombolytic. But wait, aspirin. Paramedics comes to you because you got chest pain and short of breath and you called them. On the way to the hospital, they gave you aspirin. How much? Depends, you were on aspirin or not. But 3 chewable aspirin, my time it was 100 milligram. Nowadays we have baby aspirin, 2 or 3 of them, chew please. Not entry coded. But doc, my patient has gastritis. It's better to stay alive. Gastritis can be taken care of later. Do not use entry coated. It's good for the next life. It will pop up in my intestine after 90 minutes. So it will kick in after my death. Aspirin alone, 30 to 50% change in mortality in acute coronary syndrome. Beautiful. After so many years, God forbid one of your beloved ones in front of you is crashing like this. The major medication that you can give them is aspirin. Chew. 2 or 3 baby aspirin. Some people even carry them with themselves in case that something happens to them. Some of us are at the age that we should start carrying them with ourselves. Right? So, aspirin, beta blocker, makes me live longer. Go slower and live longer? Sure. ACE inhibitor, it's an afterload reducer. ACE inhibitor, prils, or ARBs, sartans, captopril, enalapril, lisinopril, or losartan, valsartan, candesartan, any of them, ACE inhibitors or ARBs. Why? Because ACE is an afterload reducer. What is afterload? My aortic pressure. With beta blocker and ACE inhibitor, I am removing the weight from your shoulder. I am talking to the heart. I am removing the weight from your shoulder and I'm slowing down your rate. Remove the weight and slow the rate with a beta blocker and ACE inhibitor. So far, I attacked the platelet plaque with aspirin. But I haven't done anything for the coagulation factors. So I will give you heparin. Also, dual antiplatelets is better than single antiplatelets. So I am giving you Plavix, clopidogrel. Before giving the patient aspirin, my only question from the patient is, are you allergic to aspirin or not? If I am not allergic to aspirin, give me both aspirin and clopidogrel. If I am allergic to aspirin, give me Plavix. Plavix and clopidogrel is the same thing. I think Plavix was from Sanofi Aventis, if I'm not mistaken. Aspirin. Are you allergic to aspirin? No. You will give them 2 antiplatelets, aspirin and clopidogrel. I am allergic to aspirin. Okay, I will give you only Plavix. How much is the dose of the Plavix? Each Plavix tablet is 75. You will give me 4 of them, 300. So my generation doctors remember 300 milligram of aspirin, 300 milligram of Plavix. 300 aspirin, 300 Plavix. You will check my LDL cholesterol as well, but you will not wait for the results to starting me on a statin. The fact that you want to continue statin for me or not will depend on my LDL level, but 98, 95, 98%, I will need a statin. My cholesterol probably is high enough to get a statin. But no matter, you don't wait for the results. In acute coronary syndrome and non-hemorrhagic stroke, I will put the patient on a statin in emergency department because it showed mortality benefits. So far, I attacked the platelets with aspirin and clopidogrel. I try to attack the coagulation factors with heparin. But so far, I haven't done anything for the already formed clots. So far, I haven't done anything for the already formed clots because aspirin, Plavix, heparin will not do anything, will not dissolve the already formed clot. What do? They prevent from more clot formation, but I haven't done anything for the already formed clots. So I have to give something to the patient to break the already formed clots called thrombolytic, TPA. Intentionally, I am not reading your messages in the chat box because I don't want to get distracted. I want to keep my train of thoughts. You can send me messages. I will read it later. Right now, I don't want to break my train of thoughts because I don't want to forget anything to tell you. So I put a star on T to remind you that you keep it for the patient with star. Star is STEMI. If I have ST elevated MI or new onset left bundle branch block. Oh my God, what did you just say? I will talk about bundle branch block later. But we have something called left bundle branch block. If you have a new onset left bundle branch block, it's equivalent to ST elevation. Why? Because at the presence of left bundle branch block, you cannot comment on the ST segment. That's why new onset left bundle branch block is the equivalent of ST elevation. So if I have ST elevation or new onset left bundle branch block, these are the EKG changes that tells me that my patient will need thrombolytic or TPA. What is the maximum time that thrombolytics showed mortality benefits and we can use it in acute coronary syndrome? Listen to my question and answer it accordingly. Do not answer to your questions. Answer to my question, please. What is the maximum time? You can cheat, it's written there. What is the maximum time that you can give the patient thrombolytic from the time of beginning of the chest pain? 12 hours, not 90 minutes. It is not 90 minutes. It is exactly Dr. Tarambir, tablets at our time used to be 100 milligram. Do you remember? Tablets at our time used to be 100 milligram aspirin. So we were giving the patient 3 tablets to chew, 2 to 3 tablets, which is 200, 300 milligram. Nowadays, we have 81 milligrams, 81 milligram baby aspirin. So you ask the patient to chew 2 or 3 of them. 2 is 162, 3 is 243. To make your life easier, I said 300 milligram for both aspirin and clopidogrel. What is the maximum time that my patient can receive thrombolytic? That's 12 hours, not 90 minutes. You're answering your question. Do we have anything superior to thrombolytic, chemical thrombolytic? Do we have anything superior to chemical thrombolytic? Yes, PCI, percutaneous coronary intervention, or PTCA, percutaneous transcoronary angioplasty, fancy terms for balloon and stent. Go with the balloon and regress the actually plaque into the walls, put a stent there so it doesn't recur, and come out. One of them is mechanical. The other one is chemical. This one is mechanical thrombolysis. This is chemical thrombolysis, and mechanical is superior to chemical. Why? Because mechanical is like you ladies go and pick up the kids from school. And chemical is like sending your representative, your significant others, to pick up the kids. You never know they're on time or not. And you never know that the job is done or the mission is accomplished or not. It's just easier to go and do the job by yourself. When we say we do something, I'm talking about guys, when we say we do something, it means that we'll do it. You don't need to remind us every 6 months. When we say we do it, right? So mechanical is going into that clot and opening up the blockade. But thrombolytic is sending someone to do it for you. Of course, mechanical is superior to chemical, but there is a timeline for it. The timeline for mechanical removal of the clot is 90 minutes, like a soccer game. Official time of a soccer game, not the extra time, but the official time for a soccer game is 90 minutes. So as soon as your patient's arriving into your emergency department with acute chest pain and you see EKG changes like ST elevation or new onset left bundle branch block, you will call your cardiologist, your cath lab, catheterization lab. Are you available to cath the patient in 90 minutes? Yes. Prepare the patient for the cath lab. No. The second best option is thrombolytic. Best option, angioplasty. Next option, thrombolytic. Guys, 95 minutes is still acceptable. 92 minutes is still acceptable, but they have to come up with a cutoff, and that cutoff is 90 minutes. That's door to balloon, 90 minutes. The confusing part for 90% of the doctors is door to needle part. How much is the door to needle time? How much is the door to needle time? $30 minutes. And now When to give thrombolytics? When you have ST elevation, Dr. Tarambir, or when you have a new onset left bundle branch block. If you have ST elevation or new onset left bundle branch block. What do we mean by needle? Is thrombolytic. Dr. Nasima, how do you give the patient thrombolytic? With a needle, right? And that's the confusing part. Doctors say, oh my God, I have door to balloon 90 minutes and I have door to needle 30 minutes. That's the most confusing thing for a lot of doctors. That's why I hate to talk about it, about door to needle thing. I don't give a shit about door to needle, door to breakfast, door to main hall, door to the bedroom, door to the dining table. That's crazy. But you know what? If angioplasty is not available, I have to go with the second best option. For example, the closest equipped center that I can do angioplasty for my patient is 2 hour, 3 hour drive or even flight. And I have to keep the patient in our center and we don't have angioplasty in that center. So what can I do for that patient? Giving the patient thrombolytics as soon as possible, because in a stroke, time was neuron. In MI, time is muscle. That door to needle is in case that door to balloon is not available. If the door to balloon is not available, I don't want to waste time. I want to give my patient thrombolytic as soon as possible, within 30 minutes of arrival to my emergency department. How long after chest pain thrombolytics are efficient? 12 hours. In other words, if it is more than 12 hours from the onset of the chest pain of my patient, the golden time for angioplasty is over, long time ago, and the golden time for thrombolytic just passed, because it doesn't show mortality benefits to use it after 12 hours. Is the door to balloon and door to needle 90 minutes and 30 minutes now clear for everybody on board? Because that was my main mission here today. By needle, we mean thrombolytics. Up to 12 hours. Up to 12 hours. Okay. What about aspirin? It's given. Paramedics gave it to my patient. Beta blockers, sure. Mortality benefits, go slower and live longer. If you're giving me IV beta blockers, I will need cardiac monitoring. Is there any contraindication for beta blocker? Sure. Symptomatic bradycardia. The absolute contraindication for beta blocker is symptomatic bradycardia. What about asthma, COPD, these kind of stuff? They are not absolute contraindication. I will use more cardioselective agents like metoprolol, methanol, and carvedilol. Okay. But my patient will be having wheezing. Again, it's better to stay alive with a little bit of wheeze rather than to be dead, but wheeze free. ACE inhibitor, remove the load from my shoulder, baby, with an ACE inhibitor after load reducer. After my patient received thrombolytic in my emergency department, I send my patient to the ICU or CCU, cardiac care unit or intensive care unit. So my patient will receive heparin, deltaparin, enoxaparin, low molecular weight heparin. My patient already received Plavix, dual antiplatelet. It's better than single antiplatelet in MI, acute coronary syndrome. My patient received the statin in the emergency department even before the LDL level arrived. The results are back, no, but I started the patient statin. Why? Showed mortality benefits. This cocktail, Tabach cocktail, is my mortality cocktail. If you put a stent for me, this is what we discussed in the TDM class, therapeutic decision making, and we had a very obsessive cardiologist, Iranian, Dr. Nima knows him, and he approves it. So this is based on, this is cardiologist approved, just for information. So you can be sure that 90-95% accurate, if not more. If you're not a cardiologist, probably you will not need to know more, unless you want to go for the board of internal medicine. That's a different story. So if you put a stent for me and you did PTCA for me, you can check with Dr. Nassima whether the professors told them something extra than this or not. I will change my name if she says that they told something extra in medicine, in actually family medicine residency. PTCA, right, means percutaneous transcoronary angioplasty, means you put a stent for me. Patients that you put a stent for them, prescribe them clopidogrel and aspirin for 12 months. I used to say 9 to 12 months because different texts are a little bit different, but our cardiologist said that 12 months is better to remember for most of us. Prescribe them clopidogrel and aspirin. Prescribe them clopidogrel and aspirin for a year. Means for the first year after stenting, give me 2 antiplatelets. After that, I will stay on aspirin forever. But you can stop the clopidogrel. That is the management of MI. That is the management of MI. So let me go somewhere. Ladies and gentlemen, STEMI, non-STEMI, very similar to each other. Aspirin, yes. Aspirin, yes. Paramedics gave it to my patient. The only question, are you allergic to aspirin or not? If yes, do not give me aspirin. Give me alternative, clopidogrel. If no, give me both. Beta blockers, sure. Is there any contraindication for beta blockers? Symptomatic bradycardia. Someone will say my AV block, sure. Heart rate below 55, 60, different books are different. Blood pressure less than 100 systolic or less than 90, different books are a little bit different. The bottom line, symptomatic bradycardia, sure. What about asthma? I will give you more cardioselective ones. It's better to be alive with a little bit of wheeze rather than be dead without any wheeze. I have a silent chest, but I am dead. Nitrate, sure. Does it change the mortality? No, this is pain medication. The only question, when was the last time that you took your boner pills? Heparin, enoxaparin, sure, give it to me. This guy, remember, T-A-B-A-H. I started with T and then H. Yes, but only after thrombolytics. Sure, you gave me thrombolytics, and now you're giving me some anticoagulants. Guys, do not mix these guys with each other. We have antiplatelets like aspirin and Plavix. We have thrombolytic, which is TPA. We have anticoagulants, which is heparin. Do not mix them with each other. Anticoagulation is heparin. Antiplatelet is aspirin and clopidogrel. Thrombolytic is TPA. Do not mix them with each other. Sure. GP2B3A for owl level, give it to non-STEMI for owl level. A lot of doctors are so obsessed with this part of this table that the chance of it appearing in your exam is 1 in a million. You don't see the chance of 90% appearance in your exam. You want to be so focused on this part, and the chance that you have it in your exam is 1 in a million. How many times ever you had a question about this? Honestly, seriously. We have 2 internists on board. So in their exams, maybe. But the rest of you, I don't think you even remember. Most of you might not even remember the name of those medications. What do they do? These are aggregation of the platelets. In hematology, we'll talk about it. I adhere to the endothelium, right? And then I grab other platelets' hands with 2B3A receptors. With 2B3A receptors. So these are actually medications that blocks the aggregation of the platelets. Okay. In this guy, no, because I already gave you aspirin and Plavix. I already gave you aspirin and Plavix. Thrombolytics, no, because this guy does not have a star, but this guy had a star. Remember, starry. Thrombolytics for starry ST elevation, but not as good as PCI. If PCI is available in the next 90 minutes, that's superior. Sure. Calcium channel blocker? No, and no, and no. Do we ever use them? Sure, if I cannot use beta blockers. Warfarin, good way of thinking, but we never use it. Even if you want to send me home, no, I will not give you warfarin. In ischemic heart disease, there is no role for warfarin. In ischemic heart disease, where did my, found it. There is no role for warfarin. What about antiplatelets? For chronic stable angina was too much. For non-STEMI, sure, give me Plavix as well. Dual antiplatelet. For STEMI, yes. What about statin? Yes. Makes me live longer. And that's the management of acute coronary syndrome. You're welcome. So I will check your questions in a second.